So the title of the presentation has already been declared. Just to recapitulate, it all started on the March 19, 2020, when ICMR chose our laboratory among very few centers to perform the RT-PCR for COVID-19. So naturally, we were not prepared. We had very little space and very few equipments and manpower. We have only two manpower in our virology section. So this work was started on a very small scale. And initially, our services were only for the patients who were attending SGPGI. However, we were fortunate enough that our new diagnostic block was coming up, and PGI administration, our honorable director, and everybody came to help us. And overnight, the lab was extended because this new block was coming up. There was an old block. There was a huge wall between that was broken. Electricity, we had nothing, electricity, light, everything was started, and lab was started. And later our services were extended to various districts of UP, and so far we have done provided services to more than 25 districts of UP. So this is the wall I was talking about, and you can see the status of the lab that was there, and there was nothing. But after renovation, and this is how this is the left side picture. You can see it was inaugurated, and then now this is the current status of the lab. So now about the tests we are doing regularly since past 21 months. The laboratory is catering to the needs 24/7, both the state and the SGPGI. And we perform two tests. One is real-time PCR test, and second is TrueNet, which is indigenous rapid microchip-based RT-PCR testing. As per the vision of our Honorable Prime Minister, this is Make in India, and this is very good for the rapid testing, because sometimes you cannot wait for 4 to 6 hours. That is required for RT. There's urgent need, and so this proved to be very good, and the first such kit in the world. And though we started with 10 or 12 samples, but now our current capacity is 12,000 RT-PCR per day, but the lab has done up to 12,800 samples per day. And till date, we have done more than 30 lakhs RT-PCR for COVID-19, and also TrueNet. Many TrueNet, which data is not included here. And apart from testing, unlike other centers which do only testing, we are also involved with the sample collection center. So initially, one sample collection center was started on March 23rd at SBI E-Corner near PMSSSY building. Then later, as the need increased, one more booth was started at the same place for the healthcare workers. And later, one more collection booth was started near RCH. So today's CGR will cover the following topics. One, the different variants of SARS-CoV-2, including Omicron. Then it will be presented by a senior resident, Dr. Akshay Arya. Then bacterial and the viral co-infection in COVID-19 patients will be presented by Dr. Chinmay Sahu, Associate Professor in our department, and viral co-infection will be presented by Dr. Atul Garg, Associate Professor in our department. Then finally, I will summarize the data and ongoing research in the Department of Microbiology on COVID-19. Now, I'll request Dr. Akshay Arya to tell us about the variants of SARS-CoV-2. Thank you.
Thank you, ma'am, and good morning, everyone. I will be discussing briefly about the variants of SARS-CoV-2 and about Omicron. So why does this mutation occur? Mutation arises as a natural byproduct of viral replication. For more opportunities for virus to spread, more it replicates and more the chances to undergo the changes or the mutation. Other point is, for the immunological pressure mounted by the vaccination, antibodies or the monoclonal antibodies also result in the mutation. However, in the coronavirus, it makes few mutation than the most of the RNA viruses because they encode an RNA polymerase enzymes that correct some of these errors made during the replication. This was a study published in Nature articles which showed the effect of the therapies on the mutation on the spike proteins of the coronavirus. So what we can see in this figure, they have done the sequencing every 3 days till 101 days. So what they observe, after giving the remdesivir, the mutation was less, but after giving the remdesivir and convalescent plasma, which contain the passive antibodies, the mutation increased many folds. So we can say that the vaccination or the antibodies increase the chances of mutation. Now coming to some basic concepts. Mutation refer to the actual change or error in the sequence. Virus with these mutations are also called as new variants. A variant is referred as a new strain when it shows a distinct physical properties. Now, this mutation have little changes or no changes on the virus properties, but we are concerned when these mutations shows changes in the transmissibility of the virus or disease severity or efficacy of vaccine therapies or the current diagnostic tests which we are using. Now coming to the Omicron variant, as we know, we are dealing with the pandemic caused by the Omicron variant nowadays. So in the Omicron variant, carries more than 50 mutations not seen in the combination before, including more than 30 mutations on the spike protein that coronavirus used to attach the human cell. This spike protein is basically targets the attachment for the cells, and the vaccination properties also and the monoclonal antibodies basically target the spike protein only. Now some basic concept of the spike protein. For the spike protein contains three regions. One is receptor binding domain, that is RBD. One is N-terminal domain, that is NTD, and one is S1, S2 furin cleavage site. So in this Omicron variant, there are multiple mutations in the receptor binding domain and NTD. So in what they causes the resistance to neutralizing antibodies. So most of the antibodies and the vaccine target this area. So it is expected that the response of antibodies or monoclonal antibodies will decrease. So which we are seeing nowadays also. Now for the cluster of mutation occurring adjacent to the S1 and S2 furin cleavage site lead to the more efficient cell entry. So more the efficient cell entry, it will lead to the more transmissibility of the virus, which is also seen in the Omicron variant. For the nucleic acid NTD part, it is also seen in the increased infectivity. So these mutation occurring in these regions has led to the changes in the for the Omicron variant. Now, if we compare the different variants, previous variants like Alpha, Delta, with Omicron, we can see on the basis of spread, virulence, treatment, and vaccine efficacy. So what we can see in the Alpha variant was approximately 50 times more spreading than the original SARS-CoV-2 variant. Virulence, it was more severe. For the treatment part, monoclonal antibodies therapies appeared to be effective. Vaccine efficacy, current vaccines were effective. For Delta variant, up to 60 times more transmissible than Alpha variant. It was more severe than the other variant, which was seen in the second wave in India. Treatment, some monoclonal antibody treatment may not be effective, but overall it were effective for the Delta variant. Vaccines were also effective to prevent the hospitalization, illness, and the death. Now coming to Omicron variant, as discussed previously also, that because of the S1, S2 furin cleavage site, transmissibility is more compared to Delta. For the virulence part, data is early, but it suggests that the current severity of illness and death are to face this variant are very less or less. For the treatment part, this is concerning. The monoclonal antibody treatment may not be as effective against the Omicron variant because of the mutation in the RBD region. For the vaccine efficacy, breakthrough infection in the people who are fully vaccinated are expected, but the vaccine are effective in preventing the severe illness and hospitalization and the death. Now for the timeline of Omicron variant, on 9th of November, the first sample was collected from the Botswana district, South Africa. On 24th of November, South Africa make its first report and named by WHO by B11529. On 26th of November, WHO Technical Advisory Committee designated this B11529 as a variant of concern and gave it as a name as Omicron. India reported its first case on December 2nd, 2021 from Karnataka. UP first case was detected on 17th of December from the Ghaziabad. From the PGI, we reported the first case on 18th of December. As we know, the Omicron has spread to more than 150 countries and territories around the world. So what we can see in this figure, some of the Western countries, the prevalence rate has gone up more than 90%, and it is increasing nowadays. Coming to the Indian part, in India, the data suggests that total cases were around 8,000 around. In UP, the cases were 275. But these cases can be, cases are less reported because of the time taken by the sequencing and the reporting. So time taken is more, so we can assume the cases are very less compared to other variants. For the frequency of detection, what we can see in this figure, this is from December 27 to 10th of January. What we can see, there is a rise in the detection of the Omicron variant. So it is around 0.79. So we can assume that in the coming of days, it will overtake the Delta variant as a major variant in the country. On 7th of January 2022, WHO updated the report on the Omicron variant, which stated that for the transmissibility part, there is a consistent evidence that Omicron has a substantial growth advantage over Delta. For the severity of disease, data is early from the South Africa, UK, Canada suggests that there is a reduced risk of hospitalization for Omicron compared to Delta. However, it also suggests that the severity of Omicron increases with the age in the presence of underlying medical condition, as well as among the people who were not vaccinated. So vaccination is important, and the comorbidities are also important in this case. Effectiveness of the vaccine. This is a burning question which we are also facing nowadays. Are vaccines effective or not? It has been seen that the effectiveness of the vaccine has been significantly lower against the Omicron variant, which are we using nowadays, but it can be increased or it can be made effective by the booster dose, which can be homologous or heterologous. Those can be used. For the effectiveness of the current test, the test which we are using nowadays, like RT-PCR test, antigen test, or TrueNet test, does not appear to be impacted by this Omicron variant. So we can assume they are detected by this test. Preventive measure what can be taken? First is enhancing surveillance and sequencing of the cases. Second, sharing genomic sequence on publicly available database, like such as GSAT, so that we can assume if any new variant is there or not. Then reporting initial cases, performing field investigation and laboratory assessment. And the most important part, implementing effective public health measures, including analysis and science-based approaches. Thank you very much. Now I would request Dr. Chinmay Sahu, sir, Associate Professor, to present his presentation on bacterial co-infection. Thank you.
I'm going to present the bacterial co-infections and antimicrobial resistance pattern in COVID-19 patients, our data. So bacterial co-infection can occur in COVID-19 patients either as co-infection or secondary infection. Co-infection is present, the bacterial infection is present in this patient, COVID-19 patient, at the time of hospitalization, but secondary infection develops after 2 days or 48 hours after admission. There is difference between the epidemiology and the pathogenesis of the co-infection and secondary infection. The co-infective bacteria are more community-acquired bacteria like Streptococcus and Mycoplasma and Haemophilus, but the secondary infections are mostly hospital-acquired bugs like Klebsiella, Pseudomonas, and Acinetobacter, etc. So there was an excellent meta-analysis in the of the COVID-19 patients. They stated that they analyzed various studies and they stated that around 3% co-infection and 14% of secondary infection by bacteria in COVID-19 patient were seen, and overall the infection was 7%. And the bacterial infection was more in critically ill patients. Especially in the secondary infection, they found Klebsiella pneumoniae, Escherichia coli, and the Pseudomonas aeruginosa as the most common infecting bugs. And also they stated that clinical features and morbidity were more with bacterial co-infections than without bacterial co-infection. Especially the patients were older, they had more fever, they had more GI symptoms, and they had more respiratory distress, more need of oxygenation, more need of ICU stay if they were infected with secondary bacterial infection. However, most of our Western data and our Indian data were lacking. So we aim to detect bacterial co-infections in hospitalized COVID-19 positive patients in our institute between May 2021 to August 2021 during the second wave. And the presence of bacterial co-infection is determined by the presence of characteristic clinical features, and positive respiratory tract culture or positive blood culture were studied. And we included around 1019 COVID-19 positive hospitalized patients were included in this study. So we found around 5% of the patients showed positive bacterial culture either in the respiratory tract or in the blood. And the mean age of the patients was 68 years. They were older, and the males comprised the majority of the cases. Various comorbidities like hypertension, diabetes mellitus emerged as the most prevalent medical conditions, followed by COPD or asthma, chronic kidney disease, and chronic liver disease. When we compared the cases with bacterial co-infection without bacterial co-infection, we found that the age the patients were older, and the various comorbidities were similar to both the bacterial co-infection or without bacterial co-infection, but the outcomes were more severe in the cases with bacterial co-infection, like the inpatient mortality, use of ventilators, and use of vasopressive drugs were more in bacterial co-infection, and it was statistically significant. So what were the bacterial isolates? Apart from the common hospital-acquired bugs like Klebsiella pneumoniae, Acinetobacter baumannii, Pseudomonas aeruginosa, and E. coli, we found uncommon bacteria like other Pseudomonas species, Stenotrophomonas multifilia, Serratia, Ochrobacterium. These uncommon bacteria also found in COVID-19 positive patients. These were also reported by other studies in around the world also. And around the among the bugs, MDR bugs were around 60%, and XDR, extremely drug resistant cases were 13%, and multi-drug sensitive were around 28%. So among the gram negatives, we found that the second-line antibiotics retained good activity against the hospital-acquired bugs like ceftriaxone, sulbactam, EDTA, TGcycline, fosomycin, meropenem, imipenem, and colistin. They showed good activity. And among the gram positives, vancomycin, ticoplanin, doxycycline, and levofloxacin retained good activity. But what are the concerning was that during the first and second wave, there was very high overuse of the drugs azithromycin and doxycycline antibiotics. So between the pre-COVID era, the 2019-20, and between the COVID era like 2020 and 21, the sensitivity of the azithromycin decreased from 46% to 31%, and the sensitivity of the doxycycline decreased from 39% to 26%. So the key points of the study were the overall the bacterial co-infection was less. However, if there was bacterial co-infection, the patients had increased morbidity, mortality, need for mechanical ventilation, and ICU admissions. In the co-infection, hospital-acquired bugs and uncommon pathogens were more. Second-line antibiotics like colistin, TGcycline, minocycline, and carbapenems retained their activity. However, the commonly used drugs against the COVID-19 like azithromycin and doxycycline sensitivity were decreased. So now I invite Dr. Atul to present the viral reactivation.
I'll be covering the topic of cytomegalovirus reactivation in COVID-19 patients. I'll be starting with an interesting case report. This is about a 65-year-old male. This patient developed COVID-19 infection. He had respiratory distress and he had moderate ARDS. So this patient was admitted at intensive care unit of Rajdhani Corona Hospital. For next 3 weeks, the patient was in RCH ICU. He was treated with remdesivir, tocilizumab, steroids, and other supportive therapy. After 4 weeks, his RT-PCR turned out to be negative for COVID-19. Since the patient had still mild ARDS and wanted respiratory support, the patient was shifted from RCH to ICU of critical care medicine department. For next 3 weeks, the patient was okay. The patient was on support. After 3 weeks, the cultures were negative, but serum galactomannan was increased to 2. So voriconazole was added. Patient was doing okay, but suddenly by end of week 9, The patient developed severe ARDS, developed septic shock for which vasopressor support was required, and the patient was intubated and put on intensive mechanical ventilation. After the intubation, his endotracheal aspirates were collected. Bacterial culture, fungal cultures were done but were negative. Cytomegalovirus real-time PCR was also sent, and the viral loads were 21 lakh copies of cytomegalovirus per ml of endotracheal aspirate. In view of negative culture report and high viral loads of cytomegalovirus, it was decided to start the ganciclovir therapy. After 2 weeks of ganciclovir therapy, again the cultures were sent. This time, the viral loads have decreased from 21 lakh copies to 60,000 copies. However, this time Klebsiella pneumoniae grew, which was sensitive to colistin, so colistin was started. Against the samples were collected with time. However, with time it was seen that the viral loads decreased from 21 lakh copies. With 4 weeks of ganciclovir therapy, the viral loads decreased to 5,200. And at this time, the patient was doing well. The patient was discharged on 2 liters of oxygen support with a nasal prongs to a ward. Currently, the patient is doing well. These are the X-ray images. This is at the time of diagnosis of CMV pneumonitis. This is after 1 week of ganciclovir treatment. This is 2 weeks, and by the end of the 4 weeks, the ARDS was cleared. Now, with this in background, we'll come to the main research work. CMV reactivation COVID-19 patients. CMV is a DNA virus. Generally, it remains latent in the body cells. The site of latency are monocyte macrophages cells, and we have a plenty of monocyte macrophages cells in the lungs. In India, 90% of the population is CMV seropositive. That means we have an infection during our childhood, and we all are having latent virus along with IgG antibodies in the circulation. So COVID-19 is associated with rise in certain cytokines. It is well established that TNF alpha, IL-6, 10, interferon gamma, this increase during severe COVID. Now, because of the increase of these cytokines, they probably cause a reactivation of cytomegalovirus, and they play the pivotal role. Now, CMV reactivation has been largely studied in immunocompromised patients. We have a lot of publications in renal transplant patient, hematopoietic stem cell transplant patient, but there is very scanty data on CMV reactivation in ICU patient. Currently, in the international literature, there are only 2 groups, one in France, second in the Netherlands, who are working on CMV reactivation in ICU patients. The data shows that CMV reactivation is as high as 31% in ICU patients. There's a single study on ARDS which shows that almost 27% patient had CMV reactivation. Till date, there are single study on CMV reactivation COVID-19 which shows that 25% patients had a CMV reactivation. So this study was planned. This study is a prospective observational study done during the first wave of COVID-19 at RCH hospital. Samples were blood and endotracheal aspirates of SARS coronavirus 2 positive patients were collected. From every patient, 2 samples were collected. First samples within 96 hours of diagnosis of ARDS, and second samples thereafter 1 week. First, the samples were blood samples were tested for IgG CMV antibodies. If the samples were positive, then they were included in the study. And once they were included in the study, the RT-PCR was performed as per standard protocols. This is the study result. Overall, 23 patients were initially screened and enrolled. However, 2 patients were CMV IgG negative. Since we are looking for reactivation, they were not included. And overall, 21 patients were included in the study. Of the 21 patients, 8 patients developed CMV reactivation and was associated with 100% mortality. 13 patients didn't develop reactivation, and the mortality in this group was 84%. Coming to the samples, from every patient, we have collected endotracheal aspirates, plasma. Endotracheal aspirates turn out to be a better sample in these ARDS patients because it was positive in 87% of the patients. In fact, if we talk about the viral loads, that 2 endotracheal aspirates were a better sample. The median viral loads in these 8 patients were 18,000 in endotracheal aspirate and only 4,000 in plasma sample. So in an intubated patient with ARDS, we should collect endotracheal aspirates. So this is the detailed data of these 21 patients, although 21 patients is a very small sample size. However, it is difficult to get ARDS patients who are COVID-19 in a COVID ICU. So we have tried to done some analysis. It was seen that yes, diabetes mellitus, these patients have more preponderance to CMV reactivation. Overall reactivation group had a increased length of ICU stay and increased mortality. So we can conclude that yes, CMV reactivation was present in 38% of critically ill patients, and the study suggests that COVID-19 infection is a risk factor for CMV reactivation. Now, this study was done during the first wave of COVID-19. So by end of the first wave, we had a fairly good idea. Actually, it is very difficult to collect ET aspirates, that too from RCH from a COVID patient. This whole study was done as a part of my first MD thesis candidate. The topic of candidate was CMV reactivation in ARDS patients, in critically ill patients. So this 21 is a small subset of patients from that study. So by second wave, we had a fairly good idea that reactivation takes place. The case report which we discussed, this is during the second wave. In second wave, we had an idea, yes, the reactivation occurs in long-term patients who are COVID positive and are in ICU. And in several patients, we saw that yes, the reactivation is taking place. Ganciclovir was given by the department, and yes, they were fairly good results. Now coming to the last part, what are the important viral loads for transplant patients? The guidelines of societies are there that some society says 1000 copies per ml, some says 2000 copies per ml. For ICU patients, there are no guidelines. However, as a part of this thesis, we could find a cutoff, yes, that viral loads greater than 5600 are associated with poor outcome, and probably so if we have if you have a patient in your ICU, all the clinicians who are involved with the ICU patients, if you have a patients who are culture negative and there is a respiratory deterioration, we should think of CMV pneumonitis and should send a ET aspirate. If copies are greater than 6000, yes, we should think of starting encyclovir therapy. Okay, thank you very much. Now I'll invite Dr. Ujjwala Ghoshal, Professor and Head, to discuss on the testing data and research on COVID-19 from our center.
So I'll be talking a little bit about data and about the research work our department is doing. So as you can see, this is on the right side, the total number of tests done by India is huge. There are more than 71 crores. And out of these 19 lakhs, 35,000. So if you see the the positivity in India is around, total positivity is around 5%. In UP, we are better off and it is around 2%. And if we look at our own data, it is matching with the data of UP and it is around 1.8%. That is very close to 2. So, and this, what could be the cause of this difference between our data and Indian data as a whole? This is, I think, primarily because very few states like Maharashtra, Delhi, or Kerala, they have huge positivity. Their positivity is very much as compared to UP, where it is less. There are so many causes could be assigned to this. So this is a little bit about data. And if you look at the trends, so right from the beginning in the March, we started doing the tests as low as 10, and then slowly the positivity, as you can see, over the months, the positivity increased. If you see April, May, June, it kept on increasing and coinciding with the wave 1 till September. After that, the cases declined over the next few months, from October till, say, February or so. Then from the March, cases again started rising. That was the second wave. And then March, April, you can see the cases consistently increased and followed by decrease in the number of the cases. And over the past few months, positivity was very low. And we were really surprised why we are doing so many tests, so much test, because though the positivity was less, number of the samples what we were doing was not less, and thousands of samples were being sent to us from various districts. But towards the end of the December and the beginning of the January, again the cases started rising. That was the impending third wave. And now, if you look at the positivity in the January, you can see that there is a consistently increase in the number of the positivity, and it kept on rising, and still it is on the rise in many districts. And in few districts as Ghaziabad and Saharanpur, we are receiving their samples for past few days. In Ghaziabad, it is as high as 36%. In Saharanpur, it is as high as 26%. Whereas in other districts like Unnao, Raebareli, it is a bit less. It is somewhere 2%, 5%. So there is a lot of variation within the state itself. Now, what is the data on the variant? At the outset, I would like to tell you that we have very limited data on sequencing from UP, because most of the centers are not prepared or they don't have the facilities. So currently we are doing around 7 lakhs RT-PCR tests per week, but only state has the capability of only sequencing 500 or 600 samples for capability of sequencing per week. So there's a huge gap. But what we can tell you, whatever the data we have, we can tell you that before December, it was largely whatever the samples we were sending for sequencing, it was mainly the Delta variant. But now, till from the late December and especially the January onwards, whatever we are getting, it is largely the Omicron variant. Other variants are there, but very less. So more than 85% are Omicron variant, and maybe it will increase further. Now, the research on COVID-19 from the Department of Microbiology. So we have published around 15 papers, and we have extramural and the intramural projects. So I am PI for this, as PI 2 projects, and as co-PI 3 projects, and 1 intramural projects as PI. So I will discuss about a few of our important findings, few of our important research papers. So first is the post-infection functional gastrointestinal disorders following coronavirus disease 19, a case control study. It is a collaborative study between our center, where the major work has been done, and also the 3 centers of the Bangladesh, who are our collaborators there, and we work with them for past more than 10 years or so. And it was thought that since acute infective gastroenteritis may cause PIIBS, post-infection IBS, and functional dyspepsia, and we also know that the SARS-CoV-2 affects GI. So it was hypothesized that COVID-19 may cause post-infection functional GI disorders. However, there was not a single data even in the world literature. So this study was planned to see the frequency and spectrum of post-infection FGIDs among COVID-19 and historical healthy controls, and various risk factors for its development were also studied. So 280 COVID-19 patients and 264 controls were followed up at 1 month, 3 months, and later up to 6 months for the development of chronic bowel dysfunction, dyspeptic symptoms, and their overlap at 6 months for IBS, uninvestigated dyspepsia, and their overlap too. Psychological morbidity was also studied using Rome-3 psychological alarm questionnaire. And this is the results. As you can see that it was found in around 10% of the cases. And what were the risk factors associated with this? It was found that those patients who were initially symptomatic, especially those who had GI symptom at the beginning, like anosmia, ageusia, or CBD and dyspeptic symptoms, or the overlap, or those who have psychological comorbidities, they were at risk. Then this is in this paper, which was published in PLOS ONE, we assessed a chip-based rapid RT-PCR test for the SARS-CoV-2 detection of the SARS-CoV-2, that is a TrueNAT assay, and assess this diagnostic accuracy. And I would like to tell you that initially you had to do 2 tests for the TrueNAT. Initially there was a screening test and a confirmatory test. So that time we were having this kit and we assessed, and as you can see, it had around 70% sensitivity, around more than 90% specificity and negative predictive value and diagnostic accuracy was also very high. But now it has, so this test is based on initial kit we had, but now they have improved further and they have come up with a single test. So now you don't have to do 2 tests, but a single test only. And now it has further improved. So kindly make use of this test. And here the results are available within, if the time, when the sample reaches the lab, after that it takes around 1 to 1.5 hours. So when there's a need, you need the test results urgently, when you cannot wait, there's maybe acute intestinal obstruction or impending delivery or things like that, then this test is very useful. Then there's another paper, that is the spectrum of gastrointestinal symptoms in patient with coronavirus disease 19, predictors, relationship with disease severity and outcome, and it was published in Clinical Translational Gastroenterology last in 2020 December, which has an impact factor for around 5. So this work from the March till May, we had, then we were doing few samples, we had just started, but we have included around 16,313 samples, and out of which 252 were positive. So if you see here, around 252 cases were positive among this whole huge number, and they were, it had mainly around more than 85% were asymptomatic and rest symptomatic. So in symptomatic, they had both non-GI symptoms were present in around 41% cases, only GI symptoms. Around 25% patient had only GI symptoms, and around 34% had both GI and non-GI symptoms. So it was concluded that the presence of GI symptoms was a marker of it was correlated and was found to be statistically significant on univariate and multivariate analysis, that the presence of GI symptom was a marker of more severe disease and fatal outcome. Then in another paper, we evaluation of 7 commercial RT-PCR kits for COVID-19 testing in pooled clinical specimen. We know that there are many kits. Many kits were available in the market for diagnosis of SARS-CoV-2, but they were validated using the single samples. But now we are using, due to the huge number, we had to resort to pool samples. So this study was planned to compare and evaluate 7 commercially available kits for pool sample testing. And all 7 kits detected strong positive sample with low CT value, that is less than 30. But while testing weak positive pool sample with high CT value, that is more than 30, only 3 of these 7 kits showed 100% sensitivity, specificity, and accuracy. And in such cases, it should be used. Then there was this review article which we published during the first episode of this COVID-19. Yes, sir.
You should try to end in a couple of minutes, because there are lots of questions.
Okay, sir. Okay, sir. So this paper here, the focus was on the, because that it was the beginning, we did not know much. So the study focus was on the etiological viral agents, comparative genomic analysis, population susceptibility, disease epidemiology diagnosis, what could be the various animal reservoirs, lab and animal models, and so on. So it was published in Pathogen. Then we wrote another review in gastrointestinal and hepatic involvement in severe acute respiratory syndrome, acute syndrome coronavirus 2 infection, a review article published as in SARS-CoV-2 respiratory symptoms are the typical manifestation, but GI manifestation have started coming up and had been reported. Initial reports came, and it was found that the pool prevalence of the GI symptom is around 17.6%. A few studies suggested that including ours, that the presence of GI symptoms is associated with poorer prognosis. Then this was another review, the gastrointestinal, a guide to laboratory diagnosis of coronavirus disease 19 for the gastroenterologist. And this review covers the challenges which are faced while choosing the appropriate sample and test for COVID-19, the right sample at the right time from the right anatomical side with the proper precaution, all that has been described in this article. Now I have to hurry up because of the lack of time. Then there was this development of a RNA-based assay for the rapid detection of the SARS-CoV-2, which was done by the Department of Molecular Diagnosis, and we evaluated this kit and found it to be good. Then these are the couple of case reports and correspondence, and then these are for a few more evaluation of SARS-CoV-2 RT-PCR in multiple sample pools, and then this is important. This is subgenomic RT-PCR for the detection of SARS-CoV-2 in blood samples of the COVID-19 patients.
Okay, please mute yourself.
Please mute. So in this study, the nasopharyngeal and the oropharyngeal RT-PCR positive, mildly symptomatic COVID-19 patients were included, and the SARS-CoV-2 genomic RT-PCR was performed on the plasma of these patients. Genomic RT-PCR positive samples were tested for replication competent SARS-CoV-2 using novel subgenomic real-time PCR. So total of 415 patients were enrolled. Genomic RT-PCR showed that around 2.6% blood showed anemia with the SARS-CoV-2, but all were negative by subgenomic RT-PCR. So the study demonstrates that the blood is a non-infectious samples for for COVID-19 patients. Then there's another correspondence. I am very happy to share that the our institute was awarded for maximum research publication on COVID-19 by Director General of Medical Education Department. So these are the extramural projects what I have for the department. Yes, sir. And again, our lab was also facilitated for best testing as a best testing facility centers, and this is the team. So obviously all are not there, but this is the team who were there and who are working 24/7 for past 1.5 years, more than past 1.5 years. I'm very thankful. Now you can understand it is a huge work, huge teamwork. I cannot mention each and every one, but I would take this opportunity to tell you that I am very thankful to all those, including the PGI administration, Honorable Director Sir, DGME, Medical Department. This is a huge work. Everybody, Government of UP, ICMR, and our own faculty members, SR, all these staff members, and you all who support us in terms of providing technical staff and other whatever we need. So I'm really very thankful to you all. Though unfortunately, because of lack of time, I cannot mention you individually. Kindly excuse me for that. But I'm very thankful from the bottom of my heart. Thank you all.